Good afternoon, and thank you for joining our Policy Committee meeting. This meeting is being recorded. The documents which will be discussed here today are available on the event calendar on our website, which is wmc.wa.gov. They are also available in the handout section of this webinar. I'm Amelia Boyd, and I'm the Program Manager for the Medical Commission. I, along with Becca King, are the organizers for this meeting. Panelists, please make sure your line is muted if you are not speaking. Dr. Karen Domino is the chair for the Policy Committee. Once a presentation is finished, Dr. Domino will open the floor for committee and public discussion. For those of you joining us via the GoToWebinar platform, and if you would like to ask a question or speak, please use the raise your hand function or the question section. Please refrain from making inappropriate comments or you will be removed from the meeting. With that, I will hand it over to Dr. Domino.
Well, hello, welcome everyone. Sorry we went over a little bit in our panel B. I'm glad to see the other panel B members here, and panel A members I think have been waiting for us. So we have a number of items to consider today that are on the agenda. And the first item, so I don't have the whole list in front of me, but if that's there, the first one I have on my list is telemedicine rulemaking. And Mika was planning to present this.
Thanks, Dr. Domino. So yeah, basically there's been, we've been undergoing the telemedicine rulemaking process for over a year now. And there have been several items that have been moving in the legislature, as well as something national that's moving that I'll bring you up to speed on. So the legislature passed a bill that allowed audio-only telemedicine in certain circumstances. It also had a requirement that the Washington State Telemedicine Collaborative issue a report in November of this year that would deal with how to establish a patient relationship via telemedicine and if an in-person visit was truly required. So that in itself is going to come into play with whatever we did with telemedicine rules, and it will likely impact our existing policy and guidelines. The other thing that is occurring starting next week is, if you're familiar with it, the Uniform Laws Commission is a group that develops uniform laws and for adoption by states to have more streamlined approaches to things. They are considering a draft telemedicine bill that's pretty comprehensive next week at their meeting in Madison, Wisconsin. While I was gone, I was sort of volunteered as an observer for the drafting group, and I was not aware of this until about May. And so, sorry, Mr. Anderson, go ahead.
Can anybody else hear what I'm hearing?
Yeah, there's a lot of background noise, so
sort
anybody who's not,
like a
mute.
small dog barking or something.
Yeah, I thought it was like a cross-country ski machine or something like that.
Yeah. I was trying to figure out what it is.
It's not a small dog, and Melanie's laughing at me as well as Amelia because it's my daughter. She's in a Johnny jump up. I apologize. So I will try and get through this quickly without incident.
At least now I know what it is, so that's helpful. Thank you.
Yeah, is that better? So
sure, but I know what it is, so I'm good. Thank you.
Yeah. So yeah, 6-month-old. Sorry. The other thing with the Uniform Laws Commission is this comprehensive telemedicine bill that they're drafting. It's on what's called first reading this next week, and as I understand it, it will take about a year for them to get to second reading, which equals approval, and then it will be sent back to the Washington delegation for consideration and adoption via passage through the Washington State Legislature. The bill contemplates changing the definition of telemedicine, establishing a uniform way to establish a patient relationship, and it also enacts a registration provision for conducting telemedicine without being licensed in the state. From my perspective, that is the biggest hurdle, because I've always been against the telemedicine registration, because in this state, number one, it doesn't reduce any workload on our part, and if there is a disciplinary requirement, it doesn't matter if you're registered or licensed. it's still going to be the same expense to take that property right away. So I've always been, since we have the medical licensure compact, that's what I've always been in favor of. And for the folks on the call, just as an FYI, there are now 35 states participating in the compact, so it's the majority of the U.S. at this point. And Oregon looks like they're going to go after it next year, so that's going to help out as well. So with those significant items being present in the policies field, it didn't make sense to ask the committee to hold on developing some telemedicine rules for what looks to be 24 months at least, and instead rescind the 101, I believe it is, and wait until the dust settles and then at that point we can decide as a commission if we need to do telemedicine rules or not.
Great. So your recommendation then is that we rescind CR 101 and that we end the rulemaking process until this changing political landscape and things that are developing, it changes, and then bring it back. Is that right? Yes. Good. Any discussion over this item?
So moved.
Great. There was a second? Great. All in favor? Say aye, or raise your hand, actually. Great. Anyone opposed at all? Good. Thanks, Mika, for explaining. And we did enjoy, I knew it was some kind of exercise device. It's a bouncy thing. So, all right. Stem cell ruling. Amelia.
So similar to the telemedicine, stem cells are an emerging technology, pardon me. And so we did have a workshop, and the consensus was at that workshop that we have an RCW in place already. So we really don't need to pursue rulemaking at this time. That may change in the future. So our ask is that instead of pursuing rulemaking, that we create a policy or guideline around stem cells and the use of that therapy, and to rescind the CR 101.
Any discussion about this from anyone?
Yeah, I was at this meeting, and basically the law as it exists kind of restricts what we have available for us to do in rulemaking anyway. And so I would recommend that we rescind the CR 101.
So moved.
Have a second? Great. All in favor? Say aye. Anyone opposed? No. Okay, great. Next one, opioid prescribing patient exclusions rulemaking. Amelia, you were gonna talk about this one.
Yes, so we had one workshop related to adding some types of patients to our opioid prescribing exclusions. And at that workshop, they did some very thoughtful changes to what we already have in rule, and added patients that are in nursing homes, long-term acute care hospitals, residential treatment facilities. And then they made a little bit of a change from the draft that you have seen before, that they took out, or they kind of culled out the residential habilitation centers and made them their own subsection within this section. And so what our ask is here today is that that panel approved this draft language, and so we're asking to initiate the CR 102 process for this rulemaking.
Okay, thank you. Any comments or discussion about that?
Was there any controversy or heat in this discussion? Was there any?
I would say no. There was a lot of discussion around where these should be placed, and that was really it. I don't think there was any real controversy about the types of patients we were trying to exclude.
Thank you.
It would be really complex to develop rules for these organizations.
Any other comments? Can I have a motion to accept this?
So moved.
Alden, second? Great, several seconds. All in favor? Say aye. Raise your hand. Okay, and that was both the physicians and physician assistants, so we have
Correct.
it to be identical.
Thank you.
The order of items I have on my list from Mike may differ from what's in the thing, but the next one I have on Mike's list is processing complaints of sexual misconduct through sexual misconduct analysis review team. And Melanie, I guess, Mike, do you want to present this then, or you or Melanie, or both of you?
I can. I didn't want you to forget the Cures Act issue.
Yeah, I know that was listed as number 4 somewhere, but I thought since this thing was up, if that's okay, we'll just take that at the end.
Sure.
Yeah.
This policy, procedure rather, which has been in place for a few years now. In fact, Melanie's given a number of talks on this because it's gotten some attention. We brought this to you last time and we wanted to rework it. So Melanie and I reworked it. And so we have it here in front of you. Dr. Roberts sent me a suggestion. There's a word missing. A word was crossed out. Amelia, if you go down to the bottom of page 1, you'll see the next to last paragraph. It ends with the words at least one public, and then the word members is crossed out.
Yeah, I noticed that as well.
Does that not pick up with the next?
One public member commissioner. Yeah, it does fit there, but if it could be put in the same paragraph.
You're right.
Like, yeah, that's a good.
It will be.
Yeah, Scott.
I have a couple of suggestions, but I don't want to. I like it as it is. I have some wordsmithing things. I don't want to throw a monkey wrench in this if we are along in the process.
What do you think, Mike?
Oh, I'm happy to make it better.
And I don't know, it's just a couple of suggestions. The very first sentence, there's a dangling antecedent. And I don't know if I'm the only one who has to do a double take. It might be my idiosyncrasies, but the very last word on the first line, against, and I think necessarily this has to be a little bit of a passive phrase. So using the preposition there, I don't think there's a way around it. But it looks like there's a dilemma. Is it complaints against physicians or sexual misconduct against physicians? And I was just thinking we could replace the word against with perpetrated by. Would just be one suggestion. If that's not creating any ambiguity, if I'm the only weirdo who looked at that and said, wait a minute, against or by, and then it's not a big deal.
Well, the problem that I have with that is that it is the complaints that's the issue. And when you say perpetrated by, it suggests that we've already decided that they're guilty, whereas this is complaints against the physician.
Okay.
I would find that equally confusing, I think.
Okay.
I just find the word against as a problem myself, although I would say sexual misconduct by physicians. And
yeah, that's good.
Yeah. Because against made me wonder, well, who are these the physicians and the PAs that are the ones that are, you know, I don't know, that they were the ones with the complaints rather than the you know, the complainants, the public. Anyway, so this is a 4-year review. Is this not? It's just a routine 4 year. So it's already in. We already have it. So if we wanted to take some time to wordsmith it more, is that okay, Mike?
Oh, sure. We're in no rush at all. I would suggest removing the dangling antecedent by just putting a period after sexual misconduct.
I like that.
Yeah, I do too.
Yeah. I mean, Scott, did you have other or anyone else have some substantive changes? Because if we do, then I think we should work them out.
There were a couple. I did have a couple of.
Yeah.
But I think Jim
Jim has
is
some
dying to say something.
comments.
Well, I just want to remind ourselves that gender and sex are different. And so it's not a major thing. And perhaps gender, even knowing that gender and sex are different, because gender is fluid, sex is not, in the medical and research world, that even with that noted, I think gender is still probably the word that we want there. But I do want to sort of note that.
Jim, that was really the topic of two of mine as well. I think the very last paragraph on page 1, a member of each gender. We're probably looking for a member of each sex instead of a member of each gender, and then possibly even a member, something along the lines of one commissioner each who identifies as male and female, male and or female.
Yeah, that seems like a good idea. I mean, that's current.
Identifies as male and or female?
No, I don't think that's the precise thing we want to use, but something that captures the idea that we want at least one member who identifies as male and one member who identifies as female. And that's
That what
another.
number 5 says?
I'm sorry.
Isn't that what number 5 says?
Yeah, if we look on 5 on page 2, there is saying at least one public member and at least one commissioner who identifies as female. I was going to recommend that we add and one who identifies as male. The implicature there is that, and I actually agree with the implicature, is that people who identify as female are going to be more sensitive to, more understanding of, and have more expertise with regards to sexual misconduct, and I actually think that would be true if we were to measure it. But it's just something that I looked, and I wondered if somebody would take issue with that.
That isn't the reason we put that in there. The reason we put that in there is that most of the victims of sexual assault and misconduct are females. So we've gone through this with having all male panel members, and they don't have any idea what it's like to be sexually assaulted. So you have to have at least one person who identifies as a female and a public member.
So I sort of like the way that it was worded, actually,
Yeah.
Melanie. Is there a place further up that we're not catching it? Is that an issue, Scott?
Yeah, it's the at the very end of page 1, the very last line. And this goes back to what Jim was saying. It reads a member of each gender, and gender is something very different than sex. I don't know if anybody would take issue with that from the public. I mean, when I read that, I know what it means. I know that you mean a member of each sex, and probably a member who identify as male and a member who identifies as female. It's just something to keep in mind if we don't want to change it now.
I would like to not change it because I like the ambiguity of it.
What? I know. Well, I think it's important to note that there are people who don't identify as either. And I know it's a new world here, but
Yeah.
I think it's true, and we need to be part of the new world.
Yeah.
Yeah,
I
I
very
think
much
that's
share
true. I mean, we
Melanie's.
want the right language. I don't really have a good comprehension of it, but I do know I've seen things that have come my way through like my professional society where we've gotten it wrong and it needs to be corrected because this is offensive to people, some people.
Okay, well, remember that this is an inwardly facing policy. It talks about these are commissioners we're talking about. So it's not the public that's going to be reading this policy. It's going to be commissioners. So you have to have a person that identifies as a female and a person that identifies as a male.
Inward facing policy, that changes everything. Never mind.
Okay.
But I would say, I mean, I would say there are some people who identify as neither, who may be on the commission.
Okay.
Jim, are you
know what
able to add make some suggestions about how to?
No, I'm not, and I don't want to be an obstructionist here, but perhaps we should talk to somebody who has expertise in this area about gender and sex and transgender and so forth to help us, because it's it shouldn't stop the process, but I think there is expertise out there which is not hard to find about how to address this.
I agree with that. I mean, I think the issue that our society had was over pregnancy tests, and it was brought up, for female patients. Well, it ended up being brought up by an anesthesiologist who found the language to be antiquated and offensive. And it went through some efforts to get it the right language. And as I say, there is expertise to do that. So that sounds like a good idea, Jim. So do you want to bring this up tomorrow and see if there are other suggestions, or just and have a discussion, or just John was going to cover for me tomorrow? John, I think I won't make it. I'm pretty sure it's when I'm starting my cases in the morning. I have to work tomorrow because we don't have enough staff, and I did request a day off and it was denied. So
thank you for reminding me.
Yeah, or just tell them that we are still working on it, and then try to seek some advice.
Yeah.
I think that's better, Karen. I agree with that. Let's get this right out of the chute, and then we'll be in great shape.
Okay. Any other comments or suggestions about this? Okay, that's a good idea. We'll do that. Right. Next item on this list is interactive, transparent development of evidence-based policies and guidelines.
I'm sorry, I was just making my note on the last one. This is up for 4-year review. This is a policy or procedure rather that came out of a national meeting that we went to, and we came back and thought we could tighten up our procedure and make it more interactive and public for adopting policies. Frankly, we don't follow this all the time. But it's coming up for a 4-year review to see if it's still relevant. I ran this by Jimmy Bush, who had some comments. It's ideal. Let me see if I can pull up what she said. You'll notice the only thing that I knocked out was placing a notice. This is under step 5. Placing a notice of the draft policy or guideline in the commission newsletter. It only comes up 4 times a year, so it should be a little more responsive. I invite anybody to provide feedback on this procedure. Dr. Roberts did provide some feedback if you want to go over it, Dr. Roberts. So one of the issues was we really don't need to name organizations, just say stakeholders.
Right. The other thing is, I find this a little bit difficult to know what it applies to, because, and we may need to clarify what this is actually for. There are resources that are available to practitioners, such as UpToDate, that already provide best practice guidelines, and truly best practice guidelines for what we're trying to deal with are sometimes not available. There are some things that I think it does matter for. I just think it could be clarified better.
Mika, you have your hand up, is that right?
Yeah, I mean, this is a procedure. And so I always question if a procedure, one, needs to be going through the policy committee. This is effectively talking about how we would develop a policy and our aspirational goals of how it would be done. But I'm not sure that it needs to go through policy. And you know, maybe a work group can come up with how we would like policies to be developed. But I mean, I would even hesitate to say that it maybe not even belong on the website. This is really a guidance for staff on how we're supposed to go about doing this. And so I would just raise that as a question of maybe this doesn't need to be renewed, and maybe it needs to truly become a procedure that gets used internally.
I would agree with that. There's policies, and then there's the process for the policy. There's the how-tos. So I would agree with you that this probably is more of a way that you put the policies together rather than a policy itself. So I would agree that it probably doesn't need to be here.
Any other thoughts?
Job aid, so to speak.
I like that.
Yeah. So we could have a motion then to drop this as a policy, to discontinue it.
Sorry, what's the title of this again?
Interactive and transparent development of evidence-based policies and guidelines. And I agree, from the title, you don't know what it's, I think it's practice guidelines, which is different.
That's a big title.
Yeah.
It's a mouthful.
Well, as Mike says, it's a procedure, and it's something that we can use internally, but I don't think it's something that we should have on the website or be a policy.
I would love to get one of you to be on the work group. Maybe Dr. Roberts, since you provided comment on it, can help me, and anyone else who wants to work on this and make it more relevant and timely and useful.
I will help.
So we'll just, should we, what should we do then? I mean, do you want to work on it as a policy, or do you want to remove it as a policy, discontinue it now, right? And then put together a work group and come up with some new thoughts about it, whether it be a procedure only or a policy?
I think what I would recommend you do is, number one, Dr. Roberts is good, but I think Dr. Domino, since you're the policy chair, this is really going to define how things are developed and run through your committee. So you working on it, I think, is going to be kind of essential. Approval of this can certainly come to the executive committee, and just have an agreement of that is how things will be developed and operated on a procedural level. But I think this is sort of administrative, and so it could be approved on Melanie's level as well.
So we don't need to get rid of it now, right? Is that what you're saying? It's a 4-year renewal. We'll say we're not going to renew it. We'll form an internal procedure.
Correct.
Just
You can
language,
choose
though.
to
Yeah.
not renew it and then turn it
Yeah.
and then say this is just going to be a policy. It doesn't need to be approved by the commission.
Okay. Do we need to vote on that, or is that fine?
I'll defer to Amelia, but I think you might need a vote just to rescind.
Correct.
I move to rescind.
We have a second one, Christine. All right, all in favor of rescinding? Anyone opposed? Okay, so Alden and I and anyone else who's interested, and of course staff. So I'll be involved in doing that. Okay, the last item I wanted to bring up was we had a discussion of this in one of our business meetings, and it's the Cures Act. And the thing that was interesting is this is where now patients have access to information from their medical record, including things such as biopsies or x-rays, prior to when the physician assistants or nurse practitioners have had an opportunity to even review it or mate in that. And it came up interestingly. I've been hearing a bunch about it from colleagues who have patients who've received a cancer diagnosis or some questionable diagnosis, because they immediately get a little note on their eye chart that the test is in, whereas the healthcare providers are busy and they may not see that until some days later, and then they suffer with like a weekend patients of like, oh my God, I have cancer and this and that. They also came up, interestingly enough, because a lot of this is directed at outpatients, but so on an inpatient level, like our institution does make some slight delay in this, but it came up during a case where a husband of a patient undergoing surgery called up into the operating room and got the circulating nurse and asked why the nurse anesthetist put an IV in his wife's foot in the middle of a procedure. And that's because in Epic, those procedure notes, she was an ambulatory patient, so she wasn't going to be admitted to the hospital, but she's having surgery in the hospital. That came up, and he sees that immediately as soon after the practitioner files it, because anything like an intubation, an IV, arterial line in this. So it made I'm not sure, I mean, we know about it, we've heard about it right on the commission, but I don't know how many, what people are doing about it, in terms of educating healthcare providers about it and giving them some practical tips. So it made me wanted to bring it up for discussion of whether this might be something for a work group or whether it's already covered under by other folks. Anyone have any comments about it?
So Karen, we can't change anything, right? This is a federal law.
It's a federal law. It's more of, I was thinking of an educational effort
Right.
for teaching people. I mean, when this thing with the IV came up, it made us come up with a little different policy of like trying to teach people how to word things, although it's still, yeah. I mean, anyway, so that's all. I just think, I don't know how widespread everyone knows. Mika, I see your hand up, I think.
Yeah, so what is the relationship to the Cures Act to the information in the EMR going to the patient directly? Is there a specific provision that requires that? Like, I'm trying to understand the nature here.
Yeah, I think it's the Office of the National Coordinator had wanted to had an improved transparency of medical records to the patient. And in fact, the patient is the owner of the medical record. So it was done from ONC, I believe. They're the people who deal with the electronic health records. So anyone, Mike, you may know other things about it. That's sort of my background understanding.
Yeah, that's all I know. I know it's brand new. I'm looking at a news release right now. Without delay, that's the term in the statute, that patients have access to any health information in their EMR without delay.
That seems unambiguous.
It's unambiguous, but it makes problems. And Karen's got a valid point. It makes problems. We know it makes problems. Many physicians out in the world don't. And is there anything we can do to make life better for physicians that are out there in the real world? Is that kind of what you're after, Karen?
Well, I'm just wondering, I mean, just struck me as something from an educational standpoint to help all our all the colleagues in clinical care. I mean, physicians, we have physicians, physician assistants, but there are lots of other people who are doing these chartings, and to give some guidance. I don't know if the Washington State Medical Association has been thinking about this, but it just struck me as just as we give guidance concerning maintenance of records, although you tend to get complaints about that. Look, the husband was very irate when actually the nurse connected him with the nurse anesthetist. Never even, the anesthesiologist wasn't in that room at that time. And she had to take away from that patient care and discuss with the husband why a IV was placed in the foot, which was largely one of a matter of convenience for the patient positioning, and as well as safety for that, meaning when the patient is far away from you and under drapes, you may only have access to a foot. And especially with an intravenous anesthetic, you want to assure yourself that that's running in. Otherwise, that may be the only access you have, and the rest of the patient is feet away. So I don't know. That's all I was thinking, and I don't know whether it's an issue. It just struck me so after, because it came up in the business meeting a few times ago. I think Jimmy Chung brought it up.
Is this something that we can get WSMA to either work with us on or let us know what they're doing about it or something to that effect?
Well, that's what I was thinking. I mean, Melanie's been talking about joint activities, and it struck me, since I do have colleagues who are in that, the WSMA leadership. I mean, it's collegial, right? We're all collegial at work. It'd be something that could be done as a joint activity. Melanie, have they been discussing this?
No, none of the discussions that I've had so far with WISMA have been about this, but we have one next week, and I can certainly broach the subject and get the conversation started.
Mm-hmm.
I think that would be worthwhile, because I think this is sort of coming down as surprises to folks, and surprises are never very much fun.
Okay.
Yeah, I would agree. Physicians have to understand that everything they write in that medical record is going to be read by a patient. So some of the comments that have been put in medical records in the past, you probably don't want a patient to read.
Well, and this without delay.
And that's how, right. And it's how you document so that you're knowing
and
that.
Also, how do you help people with a biopsy, that they're going to have it and they will hear before you can interpret it. Right. Or a blood test.
Yeah.
And that may be something that we as physicians need to start doing up front when we talk to patients, is that you may hear about this before I do. There's nothing I can do about that. I'll help you out as best as I can. But it'd be nice to know what's going on. What is the medical society doing? What are other organizations doing? And I think getting the process started, Karen, is a good idea.
Yeah, I agree.
Thanks.
So
It's a whole new world here.
Katarina from WISMA is on if you would like to hear from her. She did say
Sure.
that they have not addressed it, but would be happy to work with us. But I'm going to unmute her in case she would like to speak.
That'd be great.
Hi, yeah, we this hasn't come up for us, but I feel pretty confident in saying we'd like love to work with you on this. I know that it definitely sounds like it could be problematic, and so a sort of united front on how to provide guidance would be helpful for sure.
Thank you. Great. Any other comments?
And just echoing, I got some information from WISMA. I started texting them at the beginning of this discussion. They're not currently doing anything, as Kat said, and they typically defer to AMA on federal issues, but they don't recall seeing much from them on that either.
Yeah, well, it's affecting local practices at an enormous level, and patients, and causing undue distress and extra stuff, you know.
Yeah.
I would make the argument on the other side of it, as I have experienced it both with myself and with my father-in-law. Getting those results in your MyChart without delay in an emergency room situation is helpful. You know, maybe maybe other folks don't understand what they're getting, but to be able to see that it's coming in and it's starting to paint a picture, and you can still ask the question of the practitioner when you see them, that is, I think, helpful. And I certainly appreciate them coming through, like when I have a family member going in for cancer screening and regular blood tests every month. It's good to see that stuff without delay, so we know, okay, they're still at the physician's location, and it looks like their electrophoresis came back, and we've got a question about that. Let's make sure to contact them while they're still there doing an infusion and to get clarification on that. So it definitely has good points to it. I absolutely see the disruption aspect of an ongoing procedure. That's kind of amazing that they got through to the operating room. But yeah, so I think we need to make sure that we see the benefits and the detractors of this.
Oh yeah, definitely the reason why it was passed is that it really is a positive thing, I think, for patients and families. That's why I was suggesting one of trying to educate practitioners, healthcare providers about this, how best to deal with it.
Yeah.
Yeah. Okay, that's all I had on that. We don't need any motions or anything, right? It's just a discussion. Yeah, great. Any other items that I missed on this list? Any new business or anything? Okay. Amelia, do we have any other comments from the public or people who signed up or?
No.
Nope. Okay. Great. So John, are you okay for doing this? I have like complex cases in the morning, and I'm afraid, you start at 8, and I'm in the middle of doing that, so I may not be available till later.
I'll stumble my way through.
Yeah, okay. Thank you.
Okay.
I appreciate it. Okay, well, let me adjourn the meeting. Good seeing everyone. Have a good evening.
Thank you all.
Right.
Bye.
Bye.
Bye.